I have a question regarding the frequency of antepartum echocardiography. How often would you do that? Especially considering what you said, Professor Yang, about the highest risk being at the end of the second trimester and beginning of the third. So if they had an echo at that time, would you not repeat it till term? Or what would you recommend?
I'll take the first crack at it. Certainly, that's why I showed you the slide about echocardiographic abnormalities, if you want to put it in quotation. In normal pregnancy, patients will exhibit valvular regurgitations, for example. And so when we do a lot of echo, I sort of go back to what I was saying yesterday. For every test, we have properties such as the sensitivity, specificity, the receiver operating curve. Not every test is innocuous, because once we find something abnormal or potentially abnormal, we have to chase it down. And we have lots and lots of examples and studies to show in chasing down these, quote, false positives, patients have come to harm. So we have to be really going back to what is the likelihood, what is the prevalence of disease in the population that we're doing the test on. So if we're doing the echo and there was a good indication initially, then yes, absolutely it makes sense to follow up during the end of second trimester to see how things are going on. But I am not advocating doing echo on everybody who walks through the door. And I would also support very strongly what Dr. Lucas said earlier. The echo is not for someone who takes a weekend course and then goes out and tries to make therapeutic decisions and diagnostic decisions. It really has to be someone who is well trained. And the case that I quoted, I wanted to highlight, there is a lack of specificity in management of these valvular diseases. And we actually put a very experienced cardiovascular anesthetist with obstetrical anesthetist. Both are very experienced to manage that case and a number of other cases. So it wasn't just sort of someone walk through the door, put on an echo, and try and, let's see what happens. It has to be a very conscientious decision and due consideration given.
Can I didn't quite hear, did you say, were you asking about echoes in individual patients? Antenatal. So I think echoes, I think, are almost a standard part of any anaesthetic management these days. 10 years ago, asking for an echo seemed to be a big deal. And in my other part of my practice, I do a lot of vascular work, and I think it would be unusual for me to anaesthetize a vascular patient without an echo these days. It's almost like doing a full blood count. It's a basic investigation. But But I also think that echoes, they're not dynamic and they're not predictive. I think that once, a patient who has cardiac disease, a pregnant patient, I think you should definitely have an echo as a starting point. And then, I'm not contradicting what you say, but I think you need to be prepared to echo in response to changes. And I think, firstly, you need to look at how that woman is during pregnancy. And if there's any change or deterioration, I think an echo should be your first point of investigation to try and assess and decide what you do next. So I think that for me, the big thing is that all the recommendations we have and all the data is all very generalized, but management really needs to be individualized for that, individualized and responsive. So she may end up having 2 or 3 echoes, or she may only have 1 echo, but I think individualized and responsive.
Thank you very much.